All right, great. It's 10 o'clock, and I believe we have most of the people who are registered for this class are logging on, so we will get started right on time. My name is John Donadio. I'm the Executive Director of the New Jersey Association of Counties, and I'm going to welcome you to the second in our series of workshops, this one entitled County Office of Emergency Management and Preparedness. And I am very pleased to really have just an outstanding panel of county OEM coordinators and just to talk about their experiences in different regions of the state that were impacted differently by COVID-19. So I think you're going to hear, some different stories in different regions, different counties of the state, but our county Office of Emergency Management Coordinators played just a critical role in managing this crisis in terms of distributing PPE equipment, managing the overall crisis, serving as a conduit between the state OEM and the municipal OEM coordinators. So they again played a vital role, and I'm very happy to have a distinguished panel here to share their experiences with you. Couple of one real housekeeping item before we get started, and I introduce the panelists. If you have a question during the session, please click on the Q&A icon on the bottom of your screen and type it in, and we will do our best to get to that question throughout the presentation. We'll try to find a good break where we can answer your question. So with that, I am very pleased to introduce, and I'll start from, if you're looking at your screen, from my left, Braden Fahey, who is the Emergency Management Coordinator in Hunter County. Braden, thank you very much for being here today. We appreciate it. And then we have from Monmouth County, Mike Opigard, who I rely on a great deal on OEM stuff over the years. So Mike is, again, the Monmouth County Office of the Management Coordinator. So thank you for being here. I appreciate it a great deal. And next we have from Atlantic County, Vince Jones, who I probably met my first day on the job back in 1998 with the New Jersey Association of Counties. So Vince, it's good to be here, and thank you for all your help and support over the years. And lastly, but certainly not least, from the Bergen County Emergency Management Coordinator, Matthew Tideman. And as we know, Bergen County was hit very hard by COVID-19, and one of the first counties, because of its proximity to New York City, that really struggled, with the pandemic. So with that, gentlemen, the show is yours. I thank you, for taking the time out of your busy schedules to put on this workshop. And more importantly, I thank you for your hard work and your leadership in serving the residents of the Garden State, not just through, the past 8 or 9 months, but throughout your careers. So thank you, gentlemen, and good luck.
Thank you. Thank you, John. Thanks, John. So this is Mike Opigard. I'm going to share my screen here with everybody. I think I'm the first one, out of the box here. So I think I'm going to get this up for everybody, and hopefully you'll all be able to see this as we get ready to go here. Okay, so again, thanks to John and NJAC for asking us to present here. We're going to talk about some challenges and some issues that we saw throughout COVID in the state. And we're going to start with just a reminder of and talk about the emergency management structure in the state of New Jersey. Remembering that, most emergencies, and we like to manage these at the lowest level of government possible, where that is the easiest and most efficient way. So our local emergency management at the municipal level is the first line of defense for dealing with most of them. And then the counties come in to support them when they're overrun, or there's a statewide emergency or multiple jurisdictions impacted, and we help to coordinate the activities there. And typically the State Office of Emergency Management, and in this event, with the state EOC, taking everything from the 21 counties that we get from all the municipalities and trying to formulate a statewide common operating picture of all that activity that's happening. And then I'm going to skip down to the FEMA, because FEMA is always a partner when these things, get beyond the state's magnitude, or, in this case, COVID was a worldwide event. So they had a lot of interaction, and they were embedded in the state EOC. With COVID, the one thing that, we kind of saw at the beginning of this is some of the state agency emergency management departments were brought into the mix, and we're kind of leading the charge on this in the beginning. Whereas typically we don't segregate the type of emergency by the department within the state or the counties that are managing this. So that was kind of a new platform or a new integration that we were not accustomed to seeing from the county emergency management side. So, and these departments, within the state, and this is by no means a dig or anything, this is just all about lessons learned, was that they actually call themselves emergency management agencies, where, when you have the State Office of Emergency Management, and you have the State Department of Health Emergency Management, and the State Division of Human Services Emergency Management, and so on and so on, it becomes a little confusing in the messages that are delivered in that aspect. So this was kind of a new integration for us in dealing with this particular event. And then on the private sector, which we all rely on real heavily, and particularly the hospitals, which we in the past have typically worked very, very well with, and many of the emergencies that we've dealt with, the hospitals are partners and right by our side at these events. But what the challenging portion of this was, and it's no secret that the long-term care centers or nursing homes were highly impacted in this particular event. And they were, their emergency plans that, for better or worse, were implemented. And, in this event, with the sheer magnitude of the long-term care centers and trying to integrate them into our entire process was the challenging role. I mean, some of the counties that are out there, there's 50, 60 of these long-term care centers that are all privately run, and their emergency plans may or may not have been adequate to respond to this event. So while we're very well and very good at integrating with the private sector, typically it's not in the sheer numbers that we saw during COVID. So just to kind of reiterate the emergency declaration process, we felt that this is kind of important to kind of touch base on again. The emergency declaration is obviously permitted by New Jersey state law, and a directive issued by the State Office of Emergency Management director, which allows counties and municipalities to declare states of emergency, local states of emergency within their jurisdictions. And this statement here is really right out of the law, and it, issued to enforce such orders that may be necessary to implement and carry out emergency management operations to protect the safety and resources of the residents of a municipality or county. And that really is the crux of what these emergency declarations are for. And typically what we see is we issue these so that we're able to prioritize critical resource allocation. So when we have jurisdictions that are competing for resources, especially in this particular event, the PPE, that we can prioritize and set policy to, deal with those critical resources. And then the next thing that these are used for is to coordinate mutual aid. They activate our inter-county mutual aid agreements, so that if we're sharing resources across jurisdictional boundaries, that we're all protected and that our responders are covered under the particular laws and regulations for workers' comp and reimbursement on a FEMA side of the house. And then the next thing that these emergency declarations, they allow us to activate plans and facilities that we have most of the time use pre-established agreements or locations that we may need. Shelters is one that we look at a lot with facilities, but I think in this particular case, a lot of those facilities that were stood up were testing centers and things like that. And then, typically the other thing that comes around in these emergency declarations is the issues of curfews. And, we know that, when we have a storm and, there's not a widespread power outages and things, we have to reduce the number of people or restrict the people that are out and about at nighttime and when there's no lights around, or the security from the law enforcement is challenged and we can't curtail a particular area here. And the big thing on this is it really has no bearing on FEMA reimbursement. We don't need to declare a state of emergency within a county or municipality to receive or to be eligible for FEMA reimbursement, right? This all comes through the process of the state doing preliminary damage assessments and us all in the counties and the state meeting a threshold that is set by the per capita numbers, which then allows the governor to write a letter to the president requesting that emergency declaration for the state or the entire state or those impacted counties. So again, the emergency declaration doesn't need to be in place at our level in order to seek FEMA reimbursement. So the next area that I get to talk about, and I'm sure it's no secret to everybody here, was the sheer number of executive orders that came out during COVID-19. And just some recap of those numbers, 85 total that were issued since February 2nd of this year. 74 of those were directly related to COVID-19. Again, knowing some of them were election related, extended the public health emergency. But as you see early on in this particular event, March and April, there were 30 executive orders issued, which basically accounts for one every day, restricting businesses from operating, limited occupancy of companies, and commandeering medical supplies. And while that was a topic that was really dealt out to the private sector, doctors and things, this was a challenge for a lot of us at the county and the municipal levels, because we thought that there was some intention on the state side to kind of control our resources that we had been stockpiling for years or were managing at the county levels. And it became quite a challenge and understanding about, whose supplies were going to be commandeered and what. And, we've never really seen this type of an executive order, at least in my career in emergency management, coming out of the state here. And then, they had these executive orders that came out about data reporting from the healthcare industry on bed status and personal protective equipment inventory. And, what happened with these executive orders was that there was not a lot of prior notice. Typically we're engaged in conference calls with the State Office of Emergency Management. And, although we may not know that the governor is going to do an emergency declaration, pre his press conference, usually the handwriting's on the wall and we can tend to see that along the way. But these were issued and, without that prior notice. And, what happened is some of these executive orders that were issued really duplicated efforts because when you got back to the healthcare facilities with data collection and PPE, all that was happening at the county and municipal levels with those entities, as we've had, great relationships with all of these facilities throughout the years and making sure that, we're capable of supporting one another in a crisis. So, what happened in the middle of this was when those executive orders came out, it basically kind of cut us out of the loop in the middle of understanding what the critical needs were at those facilities. And then we were waiting, a week or so to see the numbers and that information come back down to us from the state. So again, that was a big challenge here along the way. And then again, the number issued in the first 60 days, we were chasing executive orders around, in the emergency operations centers, trying to interpret these and look at the issues that were being presented to us, because we're a little bit more accessible than the state. So, every business had a loophole that they were trying to get to, and the legal opinion interpretation of these was quite challenging for us. While the prosecutor's offices were looped in, we were struggling to get that out when we were trying to manage PPE distribution, working on the federal medical stations, morgue, temporary morgue setups and everything. And it really hampered the response efforts, because we felt we were working on interpretation of executive orders more than dealing with the critical assets. And again, these corrective actions have all been brought up. The state has conducted lesson learned workshops in each of the 3 regions that we deal with in emergency management. And again, better communication, coordination, and consideration and consolidation of information is always one of those things that come out. And with regards to the legal opinions, we were pushing for a statewide hotline or some kind of way that the Attorney General's office could manage that communication. And then on top of the executive orders, there was a bunch of administrative orders that came out, 21 of those, and I say non-law enforcement related because there were some that are not captured in the overall administrative orders that were issued through the Attorney General's office that impacted all of us during COVID. And the particular one that stands out here was the sharing of information, that we typically would not share with responders due to HIPAA laws and stuff. And that's the positive COVID patients that live within each of the jurisdictions. And those administrative orders also identified essential businesses and constructions. And, it was challenging, to figure out which of those, sites were fit into those categories. And we did a lot of managing of those typical things. Again, with the same thing with the hotel, motel, and guest rooms, and then the beaches and boardwalks left up to the local agencies to manage, while all the other stuff was being managed, or taken care of through executive orders. So when we look at these, quite a number of challenges, combined executive orders and administrative orders, 106. Clarifications and exemptions need to be, better communicated or understood. And these combined business operations where someone might have a pet boarding entity, and they do grooming as well, and one was allowed and one wasn't, and how does that fit in? And I totally can vouch in this particular area. We spent a couple of days trying to manage that while, we had major issues going on in long-term care centers and stuff. And it just seemed like we were burdening the system as opposed to trying to get things down. And then, the gatherings of people that were out there, certainly another issue that we dealt with as this was coming out, and, the limiting of folks in the numbers, and, what was an allowable event that could have more people than not. And again, challenging and trying to get that information clarified was very difficult. We, on the corrective action side, certainly talk about the same communication, coordination, and consolidation of information and resources, the state hotline, and the state Department of Health's infectious disease reporting system in capturing stuff based on geographical or zip codes, and that having multiple effects on the jurisdictions. And then as I finish up here, just to throw a plug in for a lot of work that's been happening since last April between the County Emergency Management Coordinators Association, the New Jersey Emergency Management Association, and state office, is a working group to update the current New Jersey emergency management laws and directives. This group's been working pretty diligently for the last over a year and a half And the total intent was to take the law and establish the framework and the structure for emergency management, and then allow the directives that are issued through the State Office of Emergency Management to kind of guide the operating procedure and structure of how we operate on a daily basis, so that we didn't have to change the law every time we have a disaster and an emergency that we want to enhance the system. Gives us the structure to do that through a directive as opposed to through the legislative process. And I will say that one thing as I transition off to the next presenter is, as John mentioned, we had a great connectivity between all the counties. Matt and his folks up in the north impacted early on. So we kind of got a feel for how things were going to shape up throughout the state as it kind of migrated, from north to south, or to central down to south. So we spent many a days on calls together between the county emergency management coordinators, sharing that information, and I think that was a great lesson learned as part of the event. So with that, I'm going to unshare my screen, I think. Hopefully, and go off to the next presenter. Good? Stop sharing. There we go.
Can you guys hear me?
Yeah, we're good. We're good, Braden. We can hear you and see your presentation. So you're good to go.
Thanks, John. So in the next block here, we're going to talk a little bit about at least what I feel was the ripple effect of COVID on emergency management agencies. So, when we think about what we've typically planned for, there's a lot of things that we saw in this response, in this event, that, at least in my opinion, caught us off guard. At the onset, a lot of the plans and the procedures that we have focus on working out of our emergency operations centers. And for us, that brings 22 elements into one room, not socially distanced, working in close quarters to form that common operating picture that Mike spoke of. And, again, very early on with the consideration for continuity of government and continuity of operations in place, we realized that this event would be different, that while we've planned to work out of that room, and we've also planned for what if that room wasn't necessarily habitable, we never took it to the point of what if we all couldn't be together. And, as Mike said, building that common operating picture and having information at a moment's notice was challenging in the sense of, everyone's working either from home or from different locations. And how do we go about, pulling that information together? So coordinating the response, was definitely a challenge, more so during COVID than hurricanes or some of the natural hazards that we've faced before. I called it the ripple effect because if you consider, you drop a stone into water, it creates one wave and then the next wave and then another wave. And we couldn't deal with one wave before it was bouncing into the next one. And whether that was, because of the administrative and executive orders that Mike spoke of coming out, and we're trying to chase them down and get an interpretation of them. Or if you think back to, late February or early March, the public was hit with this idea that you should stockpile goods, the same way you do for a hurricane. But they were stockpiling before the shutdown orders were issued, before people were told to shelter in place and to stay in their homes. And so, another wave that we dealt with was issues in the supply chain, both for government, which I'm sure, is no surprise or secret to any of you, the inability to procure PPE, but also, we're telling people that if you're in this certain age bracket or demographic, you should stay home or you should avoid going to the grocery store. And by the time that was issued, the grocery stores were already seeing, challenges and shortfalls and gaps. And so that was another thing that we were dealing with. We also, from the emergency management side, were brought into the school discussion on a state level a little late to the game. So we had been meeting, I think, in each of our counties with school districts and administrators and such. But the school districts, in March developed their feeding plans, submitted them to the state, and then the state looked at them and said, well, maybe OEM should be engaged. So we're dealing with a lot of complexity there in the sense that the schools have already decided to close or been told to close. There's this issue with feeding the students that are entitled to that service. But then again, on our end, from my perspective, we're also looking at, again, that ripple effect. What's that going to do? So we closed the schools. First responders that may traditionally work from home now don't have access to healthcare. And in a county that I come from, where our first responders and our emergency services are heavily reliant on volunteers, it's again a terrible collision course, because we're taking the childcare element out for them. And then we're also introducing this illness that poses the risk of reducing staff and affecting their ability to respond in that sense. Also on the first responders and the healthcare piece, ensuring that they have the PPE that they need was challenging. How do we give them guidance when they're telling us that they don't have what they need? And the takeaway here is just that the best way to describe it is that ripple effect. One wave is colliding to the next before we can recover from the first. And so, when we think about all these issues and all these challenges that we're facing, how do we overcome it? Well, one way, that we have identified it in our county is that there's truly success in collaboration. Some takeaways that I wanted to share with the group are, our OEM has a staff member that's embedded with our health department. That the individual is funded through grant money from both sides, both emergency management and health. And they serve as a conduit and a bridge between the two departments. And so, when Mike spoke about that, some of those things that came out in the administrative orders, that 911 CAD data piece being number one, that wasn't new to us, and it wasn't a challenge. And it was the collaboration that we had built over the last several years, specifically in our preparations and response to Ebola in 2014, that made sharing that information so seamless in our county. Our OEM, our 911 center, and our health department had already discussed a model such as that and had implemented some of those best practices during Ebola and since, that it wasn't a heavy lift, and it made sense to us. A lot of counties on the OEM side are also engaged with their schools through school security and preparedness and planning, getting to the schools to discuss this topic and making sure that they had the information and the resources that they need. That collaboration, again, was already in place. We have, I think in most counties and at the state level, we have a strong COAD and VOAD program, community organizations active in disasters, or volunteer organizations active in disasters. One of the issues that we faced in this county was with our Meals on Wheels program. The folks that staffed that from the volunteer side are, again, in that demographic that was, at increased risk with regard to COVID. We already had the plans in place to unlock spontaneous volunteers or non-spontaneous volunteers at a moment's notice. And one of the takeaways is, for us, we could have done a better job to communicate that program and those resources existed, especially to our elected officials. But again, it's collaboration. If you're in the position that the four of us are in, and collaboration is not a word that you use every day, then you're probably in the wrong business. And to that point, we've collaborated very well with our first responders over the last 10 years or so. And so, when we issue guidance to them or ask something of them, that relationship already exists. On the flip side, there's also areas of improvement, as Mike said. One thing for us that was unexpected was we knew that we needed to have engagement with the business community. And early on, us and our health department worked closely with grocers and similar businesses. But one thing that spun up several weeks in, and I think most of the counties and even the state OEM experienced it, was working hand in hand with the funeral homes. certainly from a mass fatality, fatality management standpoint, but also them coming to us and saying, we don't have the PPE that we need to sustain our business operations. And it was truly the first time in the 15 years that I've been affiliated with our emergency management office that we're giving resources to a for-profit business. But at the end of the day, there was no way around it. To continue everyone's operations, that's what was needed. And the reason that mindset is important, and the reason that we have it, is because we employ something called the whole community approach to emergency management. In 2011, then FEMA Administrator Craig Fugate, during congressional testimony, outlined in detail what the whole community approach to emergency management really looked like. And it's more so, it's engaging everyone. Traditionally, we obviously, us as emergency managers, plan for these types of things on a consistent basis, and we try to work with organizational and community leaders. We try to work with fellow county departments, state agencies, municipalities, government officials. We work closely with nonprofits, but the key thing that I think a lot of programs are still trying to develop is, how do we conduct that citizen outreach? How do we get the public to buy in to what it is that we're doing, the action that we want them to take, but in a way that doesn't scare them? We need to communicate risk, and we need to communicate threats and hazards and such, but how do we do that in a way that gets return on our outreach to them rather than posing more questions? And so, I think, at least in our county, we've done a good job with this to this point. But as I said, that dynamic with the funeral homes, it led to, we overlooked a group. We knew for several years that we needed a stronger mass fatality strategy. And certainly we didn't see the numbers of, say, Matt up in Bergen County saw. But it was an issue for us, and it was a matter that we needed to deal with. And we didn't bring the funeral homes to the table before this event, and certainly they'll be at the table moving forward. But why do we push this approach? The reasons are on the screen in front of you. There's people that have a better understanding of what goes on, even in places within our county. They have a better understanding than I do. They understand the complexity. They know the capabilities and the needs that are there. There's folks on the faith-based side and the nonprofit side that have better relationships with those in the community than I may ever have. And so we need to tap into that. Partnerships, it goes hand in hand with collaboration. There's 19 emergency support functions in our county's emergency operations plan. I'm not an expert in 2/3 of them. And truly, I'm not an expert in just about any of them. But when we bring everybody to the table and collaborate in a way that gets everyone's viewpoints and their experience and expertise kind of working in sync, it's that well-oiled machine. Obviously, that's when we're going to have the most success. And as again, at the end of the day, the whole community approach allows us to leverage assets and infrastructure that's there. One thing that, again, we had a lot of success with in Hunterdon was an outreach to conduct a PPE drive, so to speak. We used our COAD plan and activated the United Way office in our county to manage donations, and we were able to collect quite a bit of PPE that was then returned to first responders and healthcare. So with that, I too will stop sharing, and I will turn it over to Vince.
Great, thank you. Bear with me as I try to share this screen.
So as Vince, as you're trying to share the screen, I have a question, maybe going back to Mike, and this is for Braden too. So this will give you a couple more minutes to upload that. How could we improve the communication between the OEM and the state OEM in particular? I know that was an issue. The county administrators and elected officials communicated on a regular basis throughout this crisis on daily briefing calls with the front office. There were times too that executive orders were issued, and we had very little notice. But what can we do? What can NJAC do too to kind of help facilitate that communication between the county OEMs and the state Office of Emergency Management?
I'll jump in to start. I think the first thing is, we've mentioned this out before. We can't manage a crisis by press conference, right? And I think that's what a lot of this boiled down to. We're partners, and we have to be looked at as partners across all the spectrums. While I know that like the governor's office certainly wants to be, initiating, these orders and stuff. But, I think there's a better way to communicate that prior to a press conference. Like, hey, we're writing this order, are there any challenges that you see with this? And maybe there could be, some little bit of dialogue in that process. And I think the other thing is to continue to push, the state for a functioning, system that we can see information and share information real time. The current system that we're on hasn't worked since it was rolled out, and I think we need to continue to push for a better system that brings all of these people together, and we can see all that information on a common operating platform.
All right, great, thank you, Mike. Braden, anything you want to add to that? I mean, that was a pretty great answer, but.
Yeah, I think, I think Mike hit the nail on the head. I think the management by press conference is just a recipe for issues. There were instances, and I know, John, you and I have spoken about it, there were instances in which we were on calls with the state OEM at the same time that the governor's office was on calls with, the representatives from each county. And the representatives from each county are being told about what the executive orders are for that afternoon. And the state OEM is telling us, well, we don't know if there's any coming. Again, we can't react fast enough. Once the order's out, we should already be able to interpret what it is and what the intent of it is. When legislation comes out, there's a statement section on it. So it's pretty,
right. It
removes any ambiguity from it. Some of the executive orders almost needed something like that. If there's not going to be a phone number to call to get their intent behind it, it should be communicated in the executive order. Here's the whereas, now, therefore. And by the way, this is what it means in like true broken down English. It's just, right. It hasn't, and as Mike said, it hasn't followed any past emergency management practice in that regard. We have emergency operations plans and such for a reason. And the way that this was managed and coordinated kind of took all of those out of the mix to some degree.
Yeah, thank you, Braden. And we did have conversations about it, as did Vince and I, and Mike and I as well. And I think, part of the challenge that we've tried to address and have to address moving forward is that there might have been a disconnect between the front office and maybe the state OEM, who played things a little bit closer to the vest and didn't necessarily want to share the information in a timely manner. So it's certainly something that, again, we've addressed, and I think we've got to continue to improve moving forward, because I think there was terrific communication. You hit the nail on the head before, not only between the county OEM coordinators, but all the county, professionals, whether it was our county administrators, our elected officials, certainly our purchasing officials and county councils and things of that nature. And that type of communication, I think just improved, over the course of the last several months, but we can certainly always get better. So Vince, are you ready for us?
Unfortunately, I'm trying to share the screen, but I am unable to do that.
Do you want me to share mine, Vince?
If you don't mind, I think, and it's only a couple slides, if you don't mind doing that.
Let's see if I can get it up here.
And while you're doing that, Mike, so I'll ask either Braden or you, Matt, on the issue of commandeering PPE early on. There were media reports and rumors. I mean, was the commandeering of the PPE, was that initiated by the federal government, or was that the state OEM controlling the PPE supply? Really, where did that come from?
I don't necessarily know that it was the state government. To a certain extent, I guess on some vendors and things, the state went in and said, hey, we're taking everything you got, and you're only going to sell to us from now on. I'm sure the federal government did the same thing. That's one of the things I'm going to touch on in the PPE section was supply and demand for PPE and price gouging and things of that nature.
All right, great. Then we'll make sure to pay attention to that. And Vince, looks like you're ready to go. So thank everyone for your patience, and Vince, it's all you.
I actually don't know. I apologize, but now I don't see anybody or a screen. Bear with me here, gentlemen. I'm not sure what happened. I just lost my entire screen now. Whatever occurred.
Can you?
Okay, I'm sorry. I apologize. There it is. Okay, we're back.
Right.
All right. Again, as everyone's heard, a lot of the concerns that we had in the middle, if you will, and then later on with the COVID was the long-term care facilities and the impact that it had to them and the assistance that the county OEMs would have to provide. As you heard, we've had all the county emergency management offices have always had a long-standing relationship with the hospitals, long-term care facilities in regards to planning emergency exercises that we conduct with them. Myself, along with some of my counterparts, also sit on a lot of state and regional healthcare coalitions that include long-term care facilities, nursing homes, the hospitals, trauma centers, as well as the New Jersey Hospital Association. So going into this pandemic, for us, the fortunate thing was that, again, we had those established relationships, like you heard, and it's extremely important to have them earlier on than in the middle of all this. Those partnerships helped us because we were very familiar with a lot of the emergency response plans with these facilities, whether it's the hospitals, whether it was some of these nursing homes, long-term care facilities. We're familiar with the management structure. We were familiar with their planning, familiar with what they had as far as equipment, and also what they did not have in regards to durable medical equipment, whether it was a ventilator or some other oxygen delivery devices. So we knew that going in. We partnered up with them to see what we could do, as well as our emergency response community, as far as the emergency medical services that early on were responding to these locations. And, I wouldn't say early on we would call it an outbreak at these locations, but it became very, made us well aware that we were going to start to see an increase in patients that would need to be removed from these facilities and then taken to the hospital. So we needed to provide some type of a link between the long-term care, the hospitals. There had to be some very good coordination and communication by way of patient care. What was required? Do they have the ability to keep these people in these facilities and isolate them? If they didn't, the hospitals had to prepare to take a large number, a surge. We were anticipating a surge on a lot of the hospitals from some of these facilities. So we quickly went to work to try to provide that link between the emergency medical services, long-term care facilities, the hospitals, and how we could help maintain that patient care in these locations. And as we were planning all this out, as you heard Braden say, is when we started to realize that getting PPE, the proper PPE, for not only our EMS and our first responders, but for these healthcare facilities, really started to become difficult, to the point of a lot of them were saying they could not get any protective equipment whatsoever, and they weren't sure what they were going to do or how they were going to effectively care for the patients and the residents in these locations. Mike, if you don't mind, the next slide. Thank you. Again, early on, a lot of these long-term care facilities did reach out to us because they quickly realized they did not have enough PPE or equipment to effectively care for their residents. There was also some confusion, if you will, as to when should they be transporting patients out, and at what point could they isolate, quarantine, or segregate some patients perhaps and care for them in their facilities if they were able to get the proper equipment. So this became a challenge for these long-term care facilities. A lot of them have never faced anything like this, where they had multiple patients with symptoms that they just could not care for. So it became very difficult. You couple that with a lot of their staff contracting the COVID-19 as well, and being unable to work. So these facilities really found themselves in a dire situation with limited staffing, inability to have PPE, and inability to care for their patients. Our county and, again, local EMS agencies also started to feel the need for PPE, the proper PPE. Supply chains and vendors were telling these agencies and these facilities that they just were not able to get the PPE. Whether it was just due to the demand was so high, or they were being redirected as they manufactured this equipment, that it was going to the federal government or was going to some other entity. This just, as we know, this was not an isolated New Jersey type event. The entire country was in dire need of PPE. So it quickly, very early on, became a shortage. We looked at what PPE we had. We started to really feel the impact, whether we would have to ration some of the PPE. And ultimately, I know down here, we ended up having to do just that. A lot of the masks, for instance, the N95 masks, we knew that they were going to have to be worn for very long periods. So, how do we decontaminate that mask so it could be used at the next shift by an individual? We started to run into shortages such as gloves and even some durable medical equipment. Ventilators. Ventilators became very scarce in the hospitals and some other facilities. So we were putting requests in to get ventilators. Unfortunately, you heard about the fatalities management piece. Body bags, trying to get a supply of body bags because of the high number of deaths that were occurring. So again, day in and day out, we were trying to coordinate all this, but with the inability to pick up the phone to place an order to get these much needed supplies. State Office of Emergency Management and the State Department of Health began to coordinate the dissemination of PPE going through the county OEMs, again, because of our relationships with these facilities and our knowledge of these facilities and how they operate. So we became the conduit to supply the long-term care facilities with the PPE, as well as the hospitals, and as well as our local EMS agencies and local first responders. So we were getting tractor trailers brought in with the PPE on pallets that had to be broken down and then divvied up to these facilities. The facilities would then come pick the items up. Some were actually delivered to them from the County Office of Emergency Management. So we quickly became experts in warehousing and breaking down supply items as we received them. Next slide, Mike, please. Thank you. And again, in the well, I shouldn't even say aftermath because we're still in this, but as we move forward, you've heard about the collaboration, which is extremely important. It's something we do every day. The communication and coordination continues. We still have to access the needs of the healthcare facilities and even the EMS, and we continue to coordinate the delivery of PPE, trying as best as we can to obtain the much needed PPE, stockpiling it or warehousing it, so that as cases start to rise again, or if we do see a surge, we will have the ability to get this equipment out to those entities that are going to need it. We're working with our long-term care facilities as far as planning and capability assessments to ensure that they can maintain their patient care. What services, what equipment do they need? A lot of them have modified their facilities to be able to isolate and keep the residents there and care for them effectively. And this way it eliminates that surge or that impact on the hospital system. So we're looking at some other measures that we can implement. Again, should we see an increase in the upcoming months? A lot of them have been been very creative in how they've redesigned their facilities as far as isolating. Planning continues, again, with the State Office of Emergency Management, state health, county health. When we start to look at the potential or the possibility of a COVID-19 vaccine becoming available, and when it is available, what we've had for years is called our point of distribution or pod plans, which the County Office of Emergency Management, along with County Health, developed to be able to dispense or distribute to not only the general population, but to the responders and other healthcare workers, medication. And these plans these plans are now ready to be implemented once a vaccine becomes available, so that we can get that out to the healthcare facilities, the hospitals, the nursing homes, the long-term care facilities, get them out to our emergency responders, and get them out to the general population once it becomes available. So again, we're still in this fight, so to speak. We're still working closely with these agencies to try to procure PPE and allow them to have the ability to keep operating. And again, it's that, you heard it, and I can't stress it enough. He was spot on when Braden said it, but that collaboration, we have to have constant day-to-day communication. If not, that's always a failure, whether it's a live event or whether we're doing an exercise or a drill, always comes down to communication. So we must maintain and keep open lines of communication. It's extremely, extremely important, especially for what we have to do and what we're going to be facing, I think, in the upcoming months. And I believe that might be the last slide, Mike.
Yes, it is.
It is.
Aaron,
I apologize for the computer glitch here, the IT issues.
Right. Can everyone see my screen there?
You're good, Matt.
Yep, you're good, Matt.
All right.
By the way, Vince, you were cool as a cucumber while trying to upload your presentation. So you did a good job. It's a good thing you're an emergency management coordinator. You didn't lose your cool. I would have been smashing my mouse or my laptop or something. So you did a good job. All right, good luck.
I think I'm going to need a new phone after this, because I think I did toss that across the room trying to call for some IT.
I was impressed.
All right, we'll kind of back clean up here, and I'll speed it up a little in the interest of time. So one of the first things I want to talk about is personal protective equipment. It was touched on by several of the other emergency managers during the presentation. But the County Office of Emergency Management quickly became a point of distribution or a pod for PPE or personal protective equipment. There was everybody looking for the same products, supply and demand of PPE, And we had a lot of our municipalities that couldn't get PPE for their first responders. We had long-term care facilities that couldn't get PPE for their staff and their patients. We had hospitals in the beginning that couldn't get PPE for the healthcare workers who were trying to treat the patients that were coming into the hospitals. And then we had all of these folks, both at a county level, a state level, and even at a national level, competing for the same exact products. So vendors quickly became overwhelmed. The shelves in all the warehouses of all of these medical supply companies quickly became bare. And the ordering process was just insane when it came to, you know, the lead times on how long it would take to potentially get, you know, a pallet of gloves or, you know, a box of N95 masks or something like that. So each county was in a little bit of a different situation in the beginning. Some counties had a nice stockpile of PPE that was put away for that rainy day, and some counties didn't have that stockpile. So in addition, same thing for certain facilities, long-term care facilities, hospitals, things of that nature. Some of these folks had a supply, you know, for, you know, a potential problem someday that was waiting to be used, and some folks didn't have anything, barely had enough on hand to get through a day or two. So we quickly had to try and get these folks some supplies as fast as we possibly could so that they can adequately protect themselves for what they were doing. We also became the PPE pass-through for long-term care facilities, which Vince kind of touched on. Just to give you a little insight as to how that came through the county OEMs, we would regularly get 53-foot tractor trailers full of pallets that would show up unannounced, sometimes very late in the day or very early in the morning. We would get a phone call to say, hey, there's a, you know, 3 53-foot trailers here that need to be unloaded. And that was problematic because we had, number one, we needed a forklift operator and a forklift to unload that. So that required staff that maybe the Office of Emergency Management didn't have direct control over. It also required a place to put that stuff once it was offloaded, because we had to store it for a day or two while we broke it down and got it ready for distribution or, you know, pickup or delivery. And the other problem was the paperwork that went along with it. So the governor's office had hired a company which was giving out quantities of PPE to specific facilities. Originally, we were getting these documents in a PDF form, which was very tough to work with. We couldn't make any edits to it. We couldn't move the columns around to view it in a better fashion. Then we progressed to getting in an Excel, which wasn't sorted. And we had to go through and sort everything. And the thing that really got time consuming was that we were provided this list of facilities and what they were supposed to get, but we weren't provided with contact information for the facility. So we had to go cross-reference multiple other New Jersey Department of Health facility lists to get the name, contact, email, and contact telephone number for these folks, and then cross-associate it with the names of the facilities. We also found that some of these facilities were no longer in existence. Some of them had, you know, adequate supplies and didn't know why they were getting so much, and some of them had inadequate supplies and were wondering why they weren't getting any. All of these things became problematic because we didn't have the answers to those questions. So it was very time consuming and manpower specific when it came to getting these trailers, breaking these things down, you know, and then getting them out. For us in Bergen County, we did a drive-through point of distribution where we had these folks come and pick it up. In some other counties, they also did the deliveries for these folks. So we also had a problem with education and personal protective equipment. A lot of times we would hear, oh, I'm out of N95 masks. They're like, well, we gave you 120 N95 masks yesterday. How could you possibly be out of N95 masks today? Oh, we had 60 ambulance calls, and there was 2 people on the rig, and they each used N95 one time, and then they threw it in the garbage. A disservice to the people who were using the N95 masks at that point, because there was none left. And, you know, an N95 can be worn, you know, for an entire shift of a healthcare worker shift at a hospital, or multiple times if it's stored properly, you know, if being used on an EMS call or something like that. And it's just something that we found a lot of people didn't understand. We also had access to the Batelli system, which was allowing us to sanitize N95 masks and reuse them. That some people were or were not taking advantage of. So we found that once we educated these people on how to properly use PPE, what PPE to use, when and how, it was a lot easier for us. for example, an N95 versus a KN95 or a surgical mask. Who should be using what type of mask and why should they be using it? We found a lot of people who are using N95 masks because that's what they heard on the news and that's what they thought was the best thing to use all the time. And then we had people driving in their cars by themselves with an N95 mask on just because they thought it was the best thing to do. So we found education was a big piece of that. Stockpiling items that weren't immediately necessary. So a lot of people, again, N95, that's the most popular mask. That's the best one. I've heard it on the news. That's what everybody says I should wear. I need, 1,000 of those. Okay. Why do you need 1,000 of those? And what are you doing with them? A lot of people have these masks and they're just in a closet and they're not being used and they can be better used somewhere else. So we quickly had to make decisions as to, who was going to get what type of personal protective equipment and why. I kind of touched on the overuse and the lack of use of PPE. We had some folks who, were overusing like the N95s all the time. And then we had some folks who were just like, I'm going to use a cloth mask and go on an EMS call in somebody's house or ride in the back of a confined ambulance with somebody who may be COVID positive with a cheap cloth mask on that barely covers my face. So we had to make sure that we were getting the word out to people about what was an approved use of PPE and what was not. Touch on the manpower hours already. Very manpower intensive when it comes to personal protective equipment. Getting it in, tracking it, and things like that. In the beginning with the state, they were giving us these spreadsheets and they were sending us pallets of PPE, and they weren't giving us box quantity of things. So they were saying, this person's going to get 1,500 surgical masks, but the case of surgical masks that came on the pallet was 2,000. So you had to open up the case and take 500 masks out because they only sent you enough stuff for what was on the spreadsheet. So you couldn't give that person 2,000 masks. Otherwise you'd be 500 short somewhere else. As we got a little further along in the process, they finally got on board with box quantity. And if they sent us a case of 2,000, then the minimum somebody got was 2,000. And then they did multiples of 2,000 from there. So things like that were very taxing in the beginning. Also, purchasing power and supply and demand pricing. We had, everybody competing for the same things. A lot of price gouging out there. A lot of fake stuff out there. A lot of PPE, people would order and they thought it was legitimate N95s or legitimate surgical mask, and they would get it, and it was not of the quality that it needed to be. And we also had a lot of problems with small municipalities. Didn't have the budget, minimum quantities and things. If you wanted masks, they said, well, the smallest order of masks I can do is 10,000. So we, had a problem. We were trying to purchase at the county for these municipalities because they couldn't use, a lot of their municipal budget to get 10,000 masks, and they didn't need that many masks, so they didn't know what they were going to do with the extra. Ultimately, this led to a cooperative purchase of PPE in Bergen County, where we purchased approximately $4 million worth of PPE for all 70 municipalities, and we handed it out to them so that we used our purchasing power and funding to do that. Last but not least, I'll wrap up with some COVID-19 testing sites. The need for testing early on was obviously critical, and a lot of people were going to the hospitals, and you had to have certain symptoms, and it was very hard to get a test, and it took a very long time for it to get back, etc. We realized quickly that we needed to get this away from the hospitals. Our hospitals were being overrun, healthcare systems being overrun, and it was simply just so that these people could get a test. And we realized that this could be done anywhere, and we could get these people away from the hospitals to allow the hospitals to focus on what they needed to do the most, which was care for the ill patients. So we came up with, we were proposed by the state for 2 FEMA community-based testing sites, which obviously one was here in Bergen and the second one down by Mike in Monmouth. And FEMA came in very late in the game with New Jersey Department of Health, and they said, will you support us in doing this? So I said, sure. We set up the first one here. We kind of drew it on a cocktail napkin and then made it happen. And it was 11 o'clock the night before we were loading the boxes into the container, hoping that the next day was going to be a success. That being said, we did 654 tests the first day in our testing site. And the only reason why we had to stop is because we ran out of large gloves. The nurses needed more PPE and we didn't have it. So that gets to the next point of the lack of testing kits and PPE. So very early on, everyone was saying testing was key, and they were convincing everyone in every county that you need to open up your own test site, etc. And they were saying, go do it. And we said, so where are we getting the test kits? Nobody. Where are we getting the PPE? Nobody can answer. You know, how are we supposed to do this? Where's the funding? Where's the staff? Where's all this stuff? I don't know. Just go figure it out. So this led to a lot of problems because we needed to now counties needed to go out and get contracts with labs. They needed to find PPE. You know, at the time we couldn't find PPE for our hospitals, our long-term care facilities, and our first responders. Now we had another task of how are we going to use PPE to protect the healthcare workers who are taking these samples at these test sites, which is very PPE driven. Every time, you know, you take a sample, you have to change your gloves, you have to change this and that. Everybody needs to be gowned up. Everybody needs to be N95, face shield, etc. So that was very problematic. After that, we kind of developed some mobile sites around the state where people are going around and doing different types of mobile testing and things like that. And that's kind of where we are today. We have a mix of, you know, hospitals doing it, doctors' offices, pharmacies, ReadyMed type places, mobile testing sites, community-based testing sites throughout the county and the state. And you know, that's kind of where we're leaving off today. And we're going to see, you know, where that brings us. Testing is now widely available, as maybe not as widely available as we need it yet, but pretty close. So that'll turn it back over to you, John.
Great, thank you, Matt. I appreciate it. So Matt, do you think that you and the emergency management coordinators across the state are more prepared for a flu and maybe a second wave of COVID that, you know, we continue to hear that this, you know, might happen over the next several weeks? Do you think you're more prepared in terms of PPA, your communication with the state, and just in general?
I do. I think the whole mask thing is going to assist us with flu season. Hopefully, if people continue to wear their masks, you know, and going in stores and being in public places and things like that, hopefully that'll reduce the amount of flu we see this year, as well as keep COVID under control. I think as far as PPE goes, we're in a better spot now than we were before. I'm not going to say that everybody has been successful in making a stockpile, but I think that most counties were successful in getting at least something, at least a 30-day supply, if not a 60 or 90-day supply. So that will be good because, you know, in the initial phase, if we do get a second wave, you know, or a resurgence of the virus, that PPE will be on hand, which will be a lot easier to manage than having to try and order it. So I think as far as the PPE is concerned, we're in a much better place today than we were 6 months ago. And as far as you know, state communication and things, I think we're moving forward. We had some after actions with the state. All, you know, central, north, and south regions had their after actions with the state within the last 2 weeks. We brought up a lot of good points, you know, and things that went well and things that didn't go so well. And we hope that those were taken back and that we're going to work on those. So I think moving forward, I think if we do get a resurgence of the virus, it should go a little smoother the second time around than it did the first time.
I have a follow-up question. Last week, the county administrators and freeholders participated in a video conference with the Commissioner of Health on the department's thoughts on rolling out of the vaccine. Have the county emergency management coordinators, and I know the county health officers have been working very hard and meet almost on a daily, you know, basis, or at least 2 or 3 times a week on this issue, and others. I mean, have the county emergency management coordinators met with the Department of Health in addition to the state OEM to kind of, and are they aware? I know this might be a silly question, but are they aware and on board with the county OEM plans to roll out vaccinations when that's ready?
Yeah, I know I can speak for Bergen. I actually represent.
And that's for anyone.
Yeah, I'm speaking for Bergen and also for the County Coordinators Association. I represent the POD subgroup for logistics with the State Department of Health, and I'm one of the 2 emergency management coordinators that are on that. So we're in direct contact, you know, with the State Department of Health about a vaccination program, you know, whether it be you know, dissemination of it or drive-through site or storage of it, et cetera. So we've had conversations about that. Also in Bergen, we're adjusting our plans, as I'm sure every county is, from the mass prophylaxis plan to a mass inoculation plan. I'd like to defer to Mike. He's obviously the president of the board and has these conversations with the state all the time. So I don't want to speak out of turn on that. I'll just say that, we are represented as emergency management coordinators at the county level with state health on the group.
And yeah, Matt, you hit it right, the nail on the head. And John, just so you're aware, we beat a drum, after this with the state that, they have to continue to look at us as partners in all of this. And as they develop these plans and procedures, we need to have representation at the table, at the beginning of the process, not, halfway through. And they've been very amendable to that. And we've been pretty successful in getting that representation at those boards. So it's been good.
Great, thank you, Mike. And we went a little over, and I appreciate, again, all of your time. I appreciate your hard work. I thought this was a terrific conversation, and the common theme that we keep hearing from the county administrators last week and our Office of Emergency Management coordinators this week is communication and collaboration. And I think we're doing that, here today, and we'll make sure that we continue to do that. So, gentlemen, thank you for your time. I again appreciate a great deal, and we look forward to seeing the rest of you next week. So have a great day.
Thanks, John.
Thank you.
Got it.
Thank you, sir. All good.
All righty.